Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today we are going to record the third of the lecture in the series of ischemic heart disease. In the earlier lectures, we discussed the epidemiology, the pathogenesis of atherosclerosis, and risk factors and prevention. And in the second lecture, we discussed chronic stable angina. And today we are going to take up this what is called acute coronary syndrome. Now, those of you who are of my age, they would know that this term is relatively new. Previously, we used to talk in terms of like unstable angina, myocardial infarction. But this term was coined about 2 decades ago because many times it is not actually possible to put your finger on one particular condition. Should you call it angina, or should you call it unstable angina, or should you call it myocardial infarction? Or if it is myocardial infarction, what type of myocardial infarction? So this term was coined because the initial approach is the same in all the types, and one type could change to other. So I think this is the concept of something acutely going on with the coronaries. That of course means that there is going on some acute ischemia. So approach is the same, and as the situation changes, our approach changes. Now, those of you who attended my last lectures, I think let me have a little quiz to see if you have grasped the message. And those who have not attended the last lecture, they could skip this part, or they could go back to that lecture and come here again. Which two of the following are least suggestive of ischemic pain? Please, emphasis is on least suggestive. I told you in my lecture that sometimes we can pick up some points which tell us that this is not ischemic pain. So these are the possibilities: diffuse central chest pain, localized apical pain, prolonged nagging pain, pain felt in the jaw during exertion, chest pain that comes only after meal. Which two of these are least suggestive? I'm sure you have figured out, but let me display the answer. Localized apical pain is usually non-cardiac. Prolonged nagging pain is also usually non-cardiac. Now let's take another quiz. Which one of the following is most suggestive of ischemic pain? It's just opposite. And the options are here: central chest pain that radiates to the jaw, central chest pain felt during swallowing only, chest pain that is partly relieved by glycerol trinitrate, chest pain that increases with neck movement, and chest pain that is relieved after meal. There may not be one perfect answer, but which one you think of all 5 descriptions of pain would be most consistent with ischemic pain? Okay, let me display the answer. I'm sure many of you would have figured out the correct answer. It is the central chest pain that radiates to the jaw. That is most typical of angina pectoris. Let's take another quiz now. Which combinations is most likely to control angina pain? Which combination is most likely to control angina pain? Of course, based on the pharmacology of those drugs, the mechanism they work, and the pathophysiology of angina. If you understand all that, then you will be able to figure out. Now, these are the options: propranolol and aspirin, propranolol and isosorboid mononitrate, aspirin and digitalis, simvastatin and clopidogrel, weight loss and fat-free diet. Which of these five you think would be most likely to relieve angina pain? All are actually used in ischemic heart disease, but there is a particular combination which is most likely to control angina pain. Let me display the answer. I'm sorry, my dog was asking for my attention also. So I think let's take the next quiz. What is the primary mechanism of action of isosorbide dinitrate to control angina pain? Here are the options: coronary vasodilatation, peripheral arterial vasodilatation, venodilatation, pulmonary vasodilatation, or splanchnic vasodilatation. Some of the options are actually quite superfluous, but I think you have to differentiate between coronary vasodilatation and venodilatation. The answer is venodilatation. Of course, it has some role on coronaries also, but mechanism which actually reduces cardiac output is this, the third one, venodilatation. More blood stays back in the peripheral veins, less is brought back to the heart, and less cardiac output and less oxygen requirement. Next quiz, please. No, I think we are done with the quiz. Now, today's topic is pathogenesis of acute coronary syndrome, and I think I showed you this slide earlier also. Somebody with coronary narrowing, somewhat with atheroma, but covered with fibrous cap, then suddenly some inflammation, it leads to rupture, and then that atheromatous components are released and that attracts platelets and fibrin. The clot is formed. Then depending upon the severity of the clot, patient could present here with pain or could present here with the more severe pain and may present with complete occlusion. And this could also actually translate into which type of acute coronary syndrome patient would present. This patient is likely to present with unstable angina. This one might present with acute myocardial infarction without ST segment elevation. And this one, of course, will result in transmural infarction and will perhaps present with ST segment elevation myocardial infarction. I would discuss these concepts in more detail in the later part of the lecture. What is acute coronary syndrome? It is actually a symptom complex. There has to be angina pain. So I think first category is anybody who is a known case of angina and there is any significant, the emphasis on significant, any significant worsening in chronic stable angina. For example, pain is now longer than usual. Pain comes on minimal exertion or at rest, or pain doesn't get relieved with rest, or pain doesn't get relieved with nitrates. So any significant change over the pattern of chronic stable angina should be viewed as unstable angina or acute coronary syndrome. New onset and persistent pain, not necessarily prolonged. Any new onset ischemic pain should be treated as acute coronary syndrome, no matter how trivial and how brief the pain is. But if it is prolonged and severe, then of course it is very sure case of acute coronary syndrome, provided the pain is ischemic. Of course, you have to rule out the non-cardiac pains, but if you're sure that this is cardiac pain and if it is new onset, it should be treated as acute coronary syndrome, because that means something actively going on in the coronaries, and that whatever going on can be reversed or can be halted. Then resting and prolonged ischemic chest pain. Somebody was doing nothing, was sitting or sleeping, and pain starts in the center of the chest, spreads across the chest, goes to the jaw, the shoulder, or the body. So anywhere, actually, you know the distribution of ischemic pain. So if the pain starts at rest, whether or not patient had history of ischemic heart disease in the past, if the pain is ischemic, that of course is acute coronary syndrome. So these are the three categories. Uh, Classification, I think, first of all, the three subtypes of acute coronary syndrome. First is unstable angina, and second is non-ST segment elevation myocardial infarction. We call it NSTEMI, no non-ST segment elevation myocardial infarction. So there is myocardial infarction, but traditional finding on ECG is ST segment elevation is lacking. Then ST segment elevation myocardial infarction. So there is ST segment elevation of certain type. I will show you some ECG, but I have a separate actually series of lectures on ECG where we would be talking more about ECG localization of infarction and also the figuring out the culprit vessel. So these are three subtypes of acute coronary syndrome. Tools of assessment, so we have to evaluate the case, and there are three tools. Of course you know them, but for the sake of completion, let me mention them one by one. First of course is history. I think nothing is more important than history when it comes to evaluation of chest pain. If you give a patient listening to the patient will actually tell you if it is ischemic or non-ischemic. So I think we already know, we have discussed the characteristics of ischemic pain. I'm not going to repeat it, but history remains extremely important. And when we listen to the story of the patient, we also try to assess the patient's background predisposition. Same story could mean different things in different type of patients. Somebody with known ischemic heart disease, even vagus chest pain would suggest acute coronary syndrome. Somebody young and without any risk factor, even quite suggestive history might not actually indicate ischemic heart disease. So I think experience will guide you when to suspect or when not to suspect. It is better to suspect than to ignore. And then we have another great tool at our disposal, that is ECG. Whenever a patient comes to you with acute coronary syndrome, our first investigation is ECG, because ECG can straight away tell you if it is infarction and what type of infarction, and that will actually determine the next course of action. The ECG might actually guide you if this patient needs to go to the cath lab, or this patient needs to stay in the general ward, or if this patient has to go to ICU or whatever. And then another test is troponins. We used to have cardiac enzymes. They are still there, but troponins, which are cardiac biomarkers, they have some great features, and they have literally replaced cardiac enzymes. I might not be able to explain it in more detail to save time, but I think troponins are much better because we have a bedside test. The test may be done in just 10-15 minutes. The result is there, and those kits for the test can be kept anywhere, so test may be possible even in the remote part of the country. So I think troponins are very useful, this test. Of course, we have the proper laboratory test, which is more reliable. We can have the quantitative levels, but at least in the emergency situation, qualitative bedside test of troponin is quite useful. So these are the three tools which we use to make the proper diagnosis of acute coronary syndrome and also to categorize a patient. Acute coronary syndrome differential diagnosis. First of all, we have suspected uh, acute coronary syndrome on the basis of chest pain, and the chest pain is prolonged and resting and ischemic in nature. So on that basis, we have suspected acute coronary syndrome, and let's see how we go further. Now, this is the pathogenesis of acute coronary syndrome. This is the normal vessel. This yellow is the atheroma, and this green part or blue part is actually the rupture which has attracted platelet, and somehow the clot is formed. That clot is rather small. Now if patient presents at this level and there may not be any infarction, this is the myocardium. Myocardium is ischemic but not necrotic, not damaged, and this would result in there would be no ST segment elevation. If you do ECG in this patient, there should be no ST segment elevation, and if you do troponins, they should be negative because there is no myocardial necrosis. So if there is no ST segment elevation and no troponins are negative, then it could be called unstable angina pectoris. Okay, provided we are dealing with ischemic cardiac pain. So ECG does not necessarily need to be normal. ECG could show something, but no acute ST elevation. And troponins are negative. There may be ST depression or ECG may look normal, and then it would be called unstable angina pectoris. Let's take the second example. Now, in this case, same pathogenesis, but somehow the clot is bigger and it has caused more critical narrowing, but not complete occlusion, and this would result in some myocardial damage. Now, because our coronaries are on the surface of the myocardium, they penetrate inward. So if there is a subcomplete occlusion, it is likely to cause ischemic damage to the endomyocardium. So the part of the myocardium which is closer to the inner surface. So partial thickness infarction of irregular size, and this may cause it may not cause ST segment elevation. Why not? Because the lead placed here would record ECG activity of this viable myocardium, and this part will not cause ST segment elevation. It might cause ST depression. So on ECG you will have no ST segment elevation, but since there has been necrosis, there would be the troponins would be positive. Okay, so out of acute coronary syndrome, if ECG does not show ST segment elevation, it may show something else, but troponins are positive. That would suggest the diagnosis of NSTEMI. That means non-ST segment elevation myocardial infarction. You could also call it non-ST segment elevation acute coronary syndrome. So let's take up the third category. In this case, either patient took longer to come to the hospital, or the patient was a little unfortunate. The clot was bigger and it almost completely occluded the vessel. So there was complete ischemia. This would result in transmural myocardial infarction. And this yellow indicates that myocardium is damaged through and through. Now in this case, because of the current of injury, there will be ST segment elevation. So ST segment elevation and Trops will be positive. So Trop will be positive whenever there is myocardial infarction. But when there is transmural infarction, only then ECG would show ST segment elevation. So this is ST segment elevation myocardial infarction. So this is basically the pathogenesis of different types of acute coronary syndrome. Complete occlusion would cause transmural infarction. Partial occlusion would cause incomplete infarction, and a non-transmural and minimal occlusion would cause just severe pain at rest. Now I call it three steps diagnostic approach to acute coronary syndrome. So whenever you are confronted with a patient with acute coronary syndrome, you apply these 3 steps, you would reach a proper diagnosis. First of all is of course history. We have discussed it in detail. And if on history you suspect ischemic chest pain, then the next thing you do is what? What do you think? You are working in the emergency, patient has landed with acute chest pain. What is the first thing you do in the diagnosis? You do an ECG. Now, ECG will actually determine the further course of action. If ECG shows ST segment elevation, of course, it has to be a certain type in at least 2 contiguous leads, and it has to be convex upward at least 1 millimeter. But depending upon the suspicion, even sometimes lesser degree of ST elevation, we consider acute myocardial infarction. So if ECG shows ST segment elevation, then the diagnosis of ST segment elevation myocardial infarction is already made. You may or may not do any further test. But if ECG does not show ST segment elevation, it may show some other abnormality, but no ST segment elevation, and patient has ischemic pain, then we have to differentiate between these 2 conditions, either non-ST segment elevation myocardial infarction or unstable angina. So what do you think would be able to differentiate between these 2? This is where there is necrosis of myocardium, actual damage to the myocardium, which would obviously show in the form of elevated troponins. And unstable angina, there is critical ischemia, but no myocardial damage. So troponins will be very, very helpful. I think since time is money, in this situation, I would do a bedside test, would also send us blood for laboratory confirmation, but I will just do a bedside test and base my further course of action on this test. If troponins are elevated on this bedside semi-quad, you will just know if it is elevated or not. If troponins are elevated, then it is myocardial infarction, and we have already seen that ECG has not shown ST segment elevation, so it will be called non-ST segment elevation myocardial infarction. Okay, so if troponins are negative, then it would be called unstable angina. So this is 3-step approach. First step, history. Second step, ECG. Third step, troponins. And on that basis, you can tell what category of acute coronary syndrome patient falls in. Now, this is the management algorithm. The previous one was the diagnostic algorithm, and this is the management algorithm. Once you have figured out that this is acute coronary syndrome, at presentation, there are certain things you do immediately. I think not in any specific sequence, all has to be done. If you have a colleague with you, some of the work that colleague can do. So you administer sublingual glycerol trinitrate and aspirin, typically 300 milligram, even if patient was taking aspirin previously, the maintenance dose. Clopidogrel, again typically 300 milligram. Now this can be done, glycerol trinitrate, aspirin and clopidogrel can be given immediately at the time of presentation or at the time of your first encounter with the patient. If the first encounter was telephonic and on telephone you had the chance of taking history, and if on the history you were reasonably sure that this is acute ischemic pain, you ask the patient to take these 3 drugs. Now in the hospital, you would start oxygen. You will put up an IV line because all serious patient or potentially serious patient need an IV line. And the pain of acute coronary syndrome is relieved with morphine, not with ordinary painkillers. and I think you need to give morphine in small dose and then repeat it. Morphine is a controlled drug, may not be available in many hospitals, so you could use nalbuphine. Nalbuphine is another drug which is just like morphine, the same dose that you could use. Typically, we start with 2.5 milligram and see the response within minutes. If there is no response, you give another 2.5 milligram. Like that, we give 10 milligram or even more. And you have to watch the side effects also. I think we will discuss them in some other detail. Then monitoring. I think all patients should be monitored, and if facility is available, you put on the ECG electrodes and monitor the ECG. And these days we also have those pulse oximeter. I think it would be a good idea to monitor their pulse oxygen also. And then you do these two tests immediately. First ECG, and to save time, at the same time maybe you can ask somebody to do the troponins, or you could do an ECG first and then decide whether or not troponins are needed. It takes about 2 or 3 minutes to record an ECG. So on ECG, suppose there is no ST segment elevation and troponins are also negative. Now for troponins to be negative, now you have to consider that they become positive only after 4 or 5 hours of the onset of the chest pain. So if patient has been having pain for the last 4 or 5 hours and troponin is negative, only then you can rule out myocardial infarction. So if that condition is fulfilled, then you would call it unstable angina. These patients may be put in the hospital, observed for some time, maybe treated with nitrates infusion, heparins or low molecular weight heparin infusion may also be given. Their other anti-anginal therapy is optimized, reassured, and then usually they are sent home. And then if there is no ST segment elevation but Trop T is positive, and we are discussing the management algorithm, this would suggest the diagnosis of NSTEMI, and this patient and the other patient who shows ST segment elevation and Trop T is positive, this is STEMI. So although these are two different categories, but both are myocardial infarctions. So both cases I think needs to be hospitalized, and both are having critical narrowing of the vessels, and we have to do something to reperfuse their vessels, to reperfuse their myocardium. There are a number of strategies to reperfuse, and of course we are going to discuss them one by one. Now reperfusion, how could we do reperfusion? There was time when we did not have this concept of reperfusion. Because that time we did not have means of reperfusion, and we just would wait for the natural healing of the wound, and we will just look for any complications and we will treat if any complication arise. But now the treatment of acute coronary syndrome has become much more aggressive. We actively try to reperfuse the ischemic myocardium by using different strategies. Now it could be pharmacological reperfusion. The plus point about pharmacological reperfusion is that it is possible in any setup. So that is the plus point. But then we have a more definite way of reperfusion, which is with this angioplasty, angioplasty, percutaneous coronary intervention. This is very definite, very reliable, but then you need to have a proper setup for that. So both are useful in the given setup. Sometimes we start with pharmacological and that doesn't work, or it might work, but then we get the facilities for intervention. We got the time to transfer the patient to a better setup, and then we can have the intervention part. In either case, either you do pharmacological therapy or you do intervention. Both are helpful, but ultimately when you do the further investigation, I think many patients would actually need coronary artery bypass grafting. Some, based on angiographic reports, some would straight away go for bypass surgery. Some would be offered angioplasty, and later on maybe they might need coronary artery bypass grafting. This is the most definitive way of reperfusion, but it's a major surgery. So all patients, I think, are first considered for angioplasty. If that is not feasible or not available or doesn't work, only then we consider coronary artery bypass grafting. So now we're going to take up these 3 points in some more detail. Pharmacological way of reperfusion is discussed in the next slide. We give nitroglycerin and isosorbide dinitrate. We give antiplatelets, aspirin and clopidogrel. We give heparin, we give low molecular weight heparin, and we also may give fondaparinux. This is actually the improved version. Low molecular weight heparin is the improved version of non-fractionated heparin. Then fondaparinux is actually that part, the pentasaccharide, I think, part of heparin which actually works. So whichever is available, this one is perhaps most effective, can be given. And then thrombolytic agents. So this is actually reperfusion. All these things are done to stop the progression of clot. So actually this is thrombolytic agents are used for the reperfusion, but they are indicated only in STEMI, not for NSTEMI. All this is done for both, but thrombolytic agents are used in STEMI only, because in NSTEMI the risks they do not clearly outweigh, the benefits do not clearly outweigh the risks. Now there are many thrombolytic agents available in the world, but in poor countries we only have streptokinase. I think I'd like to give you some more details because you would probably be using this drug. It's a thrombolytic agent, and 1.5 million international units are infused intravenously over 1 hour. So one ampule is mixed in 100 ml of normal saline as infused over 1 hour. So this is relatively a rapid infusion. The aim is to provide the drug as fast as possible. Since there could be some side effect, I think physician or the nurse or a house physician needs to be present on the bedside all the time to look for any complication, and based on how well the patient tolerates, you could actually increase the rate or you could reduce the rate of infusion. Watch for complication like hypotension or cardiac arrhythmias, and an appropriate action should be taken. Rule out contraindication. Most patients with acute coronary syndrome with ST segment elevation marked infarction, they are considered for streptokinase or for some other thrombolytic therapy unless they go for intervention straight away. But only those who have contraindication, they are ruled out. Recent intracranial hemorrhage or active internal bleeding, advanced liver disease, pregnancies, these are some of the contraindications. Now we have done with the pharmacological intervention. Now let's talk about a percutaneous coronary intervention. This, of course, is now we're going beyond the internal medicine, but of course we have to identify the person who can benefit and different types of intervention so that we can refer the patient to the proper person. There are 3 types of angioplasties. Primary means at the time of acute coronary syndrome, straight away, without even trying other drugs, you take the patient to the lab and do the angiography and do the angioplasty if that is available. So that has best results because the best chances of salvaging myocardium is with primary, but it is very resource demanding. In our country, we have very few centers where this facility is available, and we have a big population. So vast majority will not be able to avail this opportunity. Then we have elective angioplasty. That means in the acute phase, patient was managed with pharmacological therapy, but later on, whenever possible, the angioplasty was performed. And third is rescue angioplasty. That means we tried with drugs, but didn't work, and then we had to ask our cardiologist colleague for a rescue, and he or she did angioplasty. And there are various types of intervention. It could be simple angioplasty, or it could be placement of stenting. Angioplasty is just balloon dilatation of vessel. And stenting is because if you do not put a stent there, that dilated vessel will come back. So bare metal stents or drug eluting stents are placed. Drug eluting stents are those which they release something which will prevent formation of clot again, and the narrowing of the fibrous tissue which sometimes clogs the vessel again. Then thrombectomy is also a procedure. You could actually remove the thrombus, and that will open the lumen immediately. So all these are actually various types or various steps of percutaneous coronary intervention. Primary has the best result. Those who have who are relatively younger patient, I think, and suitable cases, even if they have recovered from the acute phase, they should be considered for elective angioplasty. Now the third part is coronary artery bypass grafting. Indications, of course, if there is critical narrowing, and especially if there is diffuse narrowing, and percutaneous coronary intervention is not feasible or has failed. Now, typically angiography is done by a cardiologist, and if the patient is suitable for PCI, that would be offered straight away, and most probably the procedure will be done there. Now, if patient is not suitable for percutaneous coronary intervention, that patient would be offered two solutions: either coronary artery bypass grafting, or sometime patient may not be even suitable for coronary artery bypass grafting because the disease is so diffuse. Then the only option left is medical treatment. So angiography is very important deciding factor which way patient will go. So CABG is indicated when there is critical narrowing of the main vessel, for example, left anterior descending artery, and PCI is not feasible or was tried but failed. There are various types of grafts: venous grafts, which are relatively easy, and arterial grafts, which are more durable. And only those who have is a well-developed internal memory artery, they would be a candidate for arterial grafts. Now this is the cartoon which shows you the graft. Now suppose this part of the vessel is occluded. This is left anterior descending artery. It could cause massive infarction in the anterior wall, could cause sudden death, could result in heart failure. So this is an extremely important vessel because it supplies blood to our left heart, left ventricle, which is the main chamber which provides blood circulation to the body. So you could pass, this is the graft, you could use a venous graft, and this is the venous graft, and you could also graft the internal memory artery distal to the occlusion. For example, this is the site of occlusion, and the graft will be implanted distal to the occlusion. Of course, I'm not expert, this is not my field, but as a physician, I know this much, that venous grafts are relatively easy because everybody has spare saphenous vein, but arterial grafts are more durable, only those who have well-developed internal memory artery. Of course, men also have internal memory artery. I think this is the point I would like to clarify. Now, once you are done with management of acute coronary syndrome, I think patient is usually discharged and we need to offer the secondary prophylaxis. No treatment of acute coronary syndrome is a cure. It only is a palliation. We always try to control the risk factors, and we give aspirin or we give statins in a good dose to prevent recurrence of coronary occlusion. And typically these days we give aspirin with clopidogrel. Both the double antiplatelet therapy is given for the first 12 months, and if patient is tolerating well, we may continue it because it has got more benefits. But those patients who have poor tolerability, we should try to continue them for 1 year. But of course, sometimes we have to withdraw one because of the bleeding risk. Statins, here the aim is not to control their lipids. Statins are given in a recommended dose. We call them high intensity statin. There are two high intensity statins, atorvastatin in the dose of 80 milligram or 40 milligram, and rosuvastatin in the dose of 40 milligram or 20 milligram. Should be given to all patients who have recovered from acute coronary syndrome, irrespective of their baseline lipids, and that should be continued and preferably for life. So I think there is an important concept. We're not just treating hyperlipidemia or dyslipidemia. We know that these statins, high intensity statins, they prevent recurrence of coronary disease in future. And of course, we need to control risk factors. If patient is a smoker, we must address that. If patient is overweight, we should address that. Patient is diabetic or any other risk factors, all must be controlled. Only then we can hope that coronary artery disease will be stabilized and patient would not have another coronary event. This is the summary diagnosis of acute coronary syndrome: typical and prolonged ischemic cardiac pain, no ST segment elevation on ECG, troponin negative, it is unstable angina, and no ST segment elevation, and Trop I is positive, it is non-ST segment non-ST segment elevation myocardial infarction, and if there is ST segment elevation on ECG and Trop I is positive, then we call it ST segment elevation myocardial infarction. All are types of acute coronary syndrome. The treatment approach may vary, the prognosis may vary, but all are potentially serious. So this is the summary of diagnostic algorithm and a management algorithm summary. At presentation, you give sublingual glycerol trinitrate, aspirin, clopidogrel, oxygen, IV line, morphine, and monitoring. And then we do ECG and do troponins. And based on what we find on ECG and troponin, patient may fall in this group of ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction, or unstable angina. All need reperfusion with pharmacological therapy or PCI or cabbage. So I think whatever way we can reperfuse and as early as possible to save their myocardium. And we have the option of reperfusion with SK or any other thrombolytic agent, PCI, and coronary artery bypass grafting. That was it. I hope I was able to give you some account of acute coronary syndrome. And this is Professor Aziz-ur-Rehman from Medurstand, and I'm really looking forward to see you in the last lecture of the series, which will focus on diagnosis and localization of myocardial infarction based on ECG. We can actually identify the culprit vessel also, but I will be focusing on localization of myocardial infarction because that may have some bearing in the prognosis and in the complication, and it is always nice to make a proper diagnosis with the available means. Thank you very much, and I'm really looking forward to see you in my next presentation. Professor Aziz-ur-Rehman from Medurstand. Thank you.